Good evening and good morning from India. Welcome to Senadhipan Education Foundation. The purpose of education is to replace an empty mind with an open mind. Actually, I came with an empty mind. Professor Jorge Daes is going to make it an open mind. Before that, let me go to the history of Senadhipan Education Foundation, which was launched in 2012, Jan 30, at Taj Bhavanta, Trivandrum, by none other than Professor Seon Han Kim from Korea, colorectal surgeon. He released a set of educational DVDs at this function, and then he visited our place. This is our telemedicine hall in 2012. Since then, we had contact classes, contact lectures, and hands-on training programs in our hospital. Because of the COVID, we changed this platform to online platform from July onwards this year. And actually, the logo was released by none other than Dr. Palani Velu.
Over to you, sir.
Thank you, Nisha, and thank you, Baiju, for inviting me to be.
Dr. Palani Velu released logo in July 2020. And after that, we started airing live surgeries, having live lectures with eminent faculties, having certificate courses. We have got a very good global acceptance. The last webinar, we had 790 participants across the globe. And we have one Facebook group, which is having more than 600 participants, and 2 WhatsApp groups of 256 each. And today we have 2 eminent people and the inventor of ETEP, Professor Jorge Daes is there, and Dr. Jignesh Gandhi is going to moderate this session. A few words about Professor Jorge Daes. He is the governor of American College of Surgeons. He is the director of minimal access surgery at this hospital in Colombia. And he is known as the inventor of ETEP. He is known for his contribution to the approaches in AWR. He revisited and redefined the extraperitoneal space. We are really honored to have you, sir, in this platform. Thank you for accepting our invitation and welcome to this platform. And if you check his credentials, we can see that lot of publications are there. And if you see the publications, you can see that the publication, he started publishing papers from 1999 onwards. That too, again, as inguinal hernia area only, 1999. And still he is publishing papers. You can see that the 2020 itself, there are 3 publications. In the COVID era also, he is publishing papers. He is a researcher, a good inventor of new techniques. I'm not going to the details because Jignesh has something to say about him. He is a well-known figure in the international arena of AWR and bariatric surgery. To moderate, we have the young enthusiastic surgeon from KM Hospital, Mumbai, Dr. Jignesh Gandhi. He is committed to teaching. I have seen him teaching his students in cadaver and otherwise, and he is very much committed to teaching his students. Actually, we seen as a star in IHC Delhi last year. He is known as a champion in AWR. And a lot of international faculties have agreed to join this platform today. Dr. Danny Rosen has already joined. He is from Israel. Professor Jan Kukleta is going to join from Switzerland. Johan from France. Brian Jacob from New York. Gustav from Brazil. David Lore already joined from California. Yuri Noisky is going to join from Columbia University. Dr. Barbara has already joined. Victor Radu has already joined. Lot of eminent people are there now in the online. Next week, we are going to have a very eminent person, Dr. Shailesh Pundambekar. It's a entirely different topic, uterine transplant. He is the first surgeon to do uterine transplant in India, probably second surgeon in the world. Few instructions today. Zoom participants, all participants are requested to mute their mic on entry. If possible, kindly acknowledge by name your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene between the talk. Everybody will be given permission to unmute their mic and speak if they have any doubt or how to discuss. If you are on a portable device, please mute your audio and hide your video. And while Professor Jorge is giving talk, please hide your video so that the clarity of the presentation will be more if you hide your videos. And if you want to contact us, 3 emails are given: senadhipan@gmail.com, Jorge Daes @gmail.com, jigneshkem@gmail.com. Over to Dr. Jignesh.
So I will not take much time, and welcome, Professor. Good morning to you, and thanks for consenting for today's meeting. Everyone is looking forward for your talk, and your addition of an additional vowel, which I heard in the SAGES meeting, the E, has made a revolution in the field of hernia today. So the floor is all yours, Professor. If you can just share your screen and we can start with your lecture. Thank you.
Sorry about that.
That's fine. We'll wait.
Well, thank you very much, Jignesh Gandhi, for this kind invitation. I'm happy to be here. And I want to thank you also to the Senadhipan Foundation for the opportunity to share this knowledge with all of you today. These are my disclosures. The extraperitoneal space extends from the peritoneum to the investing fascia of muscles in the anterior, lateral, and posterior, and in the pelvic walls, thereby surrounding the peritoneal cavity. The anterior and lateral aspect of this space is very small, but here is where takes place the extraperitoneal repair of ventral hernias. We usually have resort to the open approach through the cavity to repair the hernias, or transperitoneally to repair the hernias from below. It is amazing, it is fantastic that we can repair hernias in the same space where they occur. That's the extraperitoneal space. What are the general advantages of working in the extraperitoneal space? Well, there are, in theory, a decreased risk of bowel injury, less need for bowel retraction, and as a consequence, less postoperative ileus. There is less potential for adhesion formation and its consequences, and less adverse hemodynamic effects when compared with the intraperitoneal approach. But there are disadvantages. A steep learning curve, and that requires a proper training, Orientation in this space is difficult. Pneumoperitoneum may compromise the space. Prior extraperitoneal surgery may contraindicate the procedure. And the creation of a large potential space give the opportunity for complications like hematomas and seromas to develop. There are three ways to access the extraperitoneal space: the open one, the hybrid, and the best example of a hybrid approach is the E-Milus technique described by Rainpool, and the totally endoscopic approach that is the main topic of this presentation. Here's the history of the totally endoscopic extraperitoneal approach for the repair of our surgery. It was first described by Bartel in 1969. Wickham and Miller described the use of CO2 in 1993, facilitating the procedure. Gore introduced the balloons for retroperitoneal dissection, and then Hirsch introduced the balloon for extraperitoneal dissection for hernias. Until this time, most of the procedures were gynecologic or urologic procedures. But then TEP popularized around 1994, precisely with the introduction of the balloon by Hirsch. Others like Miseres in 2002 describe a totally extraperitoneal approach for really small midline hernias without closing the defect and with really little consequence. It was not, the technique was not embraced nor popularized, but he has merit because he was ahead of his time, no doubt. And then we described the ETEP approach in 2009. Well, when I moved to start my practice in Barranquilla, a city with a port and seaport on the north coast of Colombia in the late 80s, we foresaw the revolution of the minimal invasive approach, but as many surgeons around the world, but without lack of evidence, it was impossible to sell this technique to the most glamorous institutions in the city. So we had to move to a small clinic. It's called Clínica Bautista in Barranquilla, where a formidable surgeon, missionary, and friend, Dr. Robert Edwards, really embraced our project. And then we started our practice of the minimally invasive approach. Soon after, we were disappointed with the open inguinal hernia repair and encouraged by Ed Felix, who at the time was fighting the establishment at the clinical meetings of the American College of Surgeons with his convincing arguments, and his baseball cap always wore backwards as a sign of rebellion against the establishment. We really crossed the bridge to minimal invasive inguinal hernia repair without ever looking back. Then the TEP technique has already been described in both sides of the Atlantic by Kernan, Fersley, and Duluc. So we descended upon Memphis, where a Southern gentleman, Dr. Guy Beller, was teaching one of the most popular courses on TEP in the world. The technique Dr. Beller has taught since, and we taught in many courses, has remained unaltered for over 25 years. And to our disappointment, it has very low implementation rate. But we still thought that the TEP technique was the closest to ideal. And one day in 2009, looking for ways to improve the surgical space to facilitate the technique, we came up with the concept of the ETEP technique. The E, small e, means enhanced or extended view, and we define it as a set of maneuvers and strategies undertaken to enhance a usable extraperitoneal space for the repair of inguinal, ventral, and lumbar hernias. And those maneuvers and strategies are summarized here. A remote access and creation of the space, division of its natural boundaries, flexible port setup, and sometimes a direct access to the pre-peritoneal space from outside the semilunar line, as you will see. So in a few months, we have collected more than 30, we have performed more than 30 ETEP inguinal hernia repairs, some of them in very complex cases. We published our experience, first in Spanish, and then in English in 2012. We conducted many clinical immersion courses in our region, and we move on to repair other hernias, especially Spigelian hernias and also ventral hernias, M4, suprapubic ones. And we published our first ETEP repair of L4 lumbar hernia in 2015. But let me tell you that this technique would have been a kind of provincial technique, if not for a group of smart surgeons and friends that we dubbed the Band of Brothers. David Chep, for example, helped us conceptualize ETEP more as a concept than a technique, a way to take advantage of the potential of the extraperitoneal space beyond the known retzius and bogus spaces. Igor Belyansky really revolutionized the field when he described the crossover, a way to go from one rictus space to other. And when he started implementing these techniques with the robot. So he opened the doors really to the ETEP ventral and incisional hernia repair. Yuri Novitsky not only described the posterior component separation TARC technique, but in one of his visits to Barranquilla, he witnessed one of our ETEP operation for inguinal hernia and invited us to publish in his now very popular textbooks of surgery, hernia surgery. And finally, with Brian Jacob at the helm, the international hernia collaboration allowed a worldwide dissemination of this technique. Here, let me show you the traditional TEP technique. The camera in the traditional TEP technique is placed in the red spot, and all the blue stripes you see are possible places for the camera placement on the ETEP technique. These are the instruments we usually use for the ETEP or inguinal hernia repair. And let me tell you, the most important one of those is this, is an S pediatric retractor. It facilitates the access to the extraperitoneal space. Let me show you how we do it. The first part is devoted all to the ETEP inguinal hernia repair. So here's a video that summarizes our port setup for this technique.
The two most common port setup for the ETEP technique are this one, in which the camera port is placed on the flank opposite the hernia site, in this case a left inguinal hernia, and in which the arcuate arch or Douglas line in general does not interfere with the vision of the space and has the added advantages of a large space and triangulation. And this one, in which the camera port is placed in the upper lateral quadrant of the abdomen, again on the same side of the hernia, this is a left inguinal hernia. And because of the distance the camera has to cover, the arcuate arch sometimes interfere with the vision of the space. In those cases, we divide it, and we are going to show you how we do it. The patient has a left inguinal hernia, and we chose the initial incision, in this case, in the upper left quadrant. The balloon dissector is slided over the posterior aponeurosis and is inflated. And through the inflated balloon, we can observe a direct hernia. We desufflate the balloon dissector and replace it with a 12 millimeter trocar, being careful not to activate the blade. We insufflate the space and infiltrate through the umbilicus. In this case, this is going to be our left working port. Then we make a 5 millimeter incision inside the umbilicus and introduce the trocar, keeping the same angle as in the needle. Through this left working port, we use a dissector to prepare the area for placement of the right working port, as you can see here. And under vision, we place this 5 millimeter trocar in the right lower quadrant. This is the port distribution. Surgeon and camera operator are on the same side, opposite the hernia side, with good ergonomics. Often with this distribution, the arcuate arc is divided, and the way to do it is to dissect peritoneum free from the posterior fascia and dividing the arcuate arc laterally, but medial to the semilunar line. It is the same approach we use for the bottom-up TAR. Using a 5 millimeter camera through the lateral port make this procedure much easier and under perfect vision. Here's an example. A 5 millimeter camera is placed through the lowest trocar. And through the upper trocar, we use the dissector to dissect the peritoneum free from the posterior rictus sheath from lateral to medial. And then we divide the posterior rictus sheath and the arcuate line medial to the semilunar line. We didn't suspect 9 years ago that we were performing a bottom-up TAR. This is one of the most common approaches, is the ETEP from the left flank, in this case for a right inguinal hernia. We follow the steps we described before, that the balloon dissector should go over the arcuate line and then turn to the right. And we try to insufflate the right side while keeping our left hand over the left inguinal region to force inflation on the proper side. Here we're replacing the balloon dissector with another trocar. And please observe here how the arcuate line interferes very little to the vision of the space using this approach. Here we're trying to put first the umbilical port without success. So we dissect the place of the left working port on the left flank, and we introduce that port first. That will help us to dissect the umbilical area and to divide a little the posterior rictus sheath at this level to facilitate placement of the umbilical port under vision. There are numerous other options to place the working port. The port setup for a bilateral hernia is exactly the same we just described coming from the flank, with addition of a 5 millimeter port on the opposite flank to facilitate the repair of the contralateral hernia. Working ports are placed high to avoid interference with mesh plate.
Here are some of the pitfalls and pearls of each of these steps. On the creation of the space, angling the table at the costal margin facilitates introduction of the balloon dissector. The skin incision should be far or a little bit far from midline and from the linea semilunaris. And the skin incision and the incision over the anterior aponeurosis should be in the same axis. This facilitates placement in the balloon in the proper plane. Avoid inflating placing and inflating the balloon under the symphysis pubis, because that could create bleeding and damage to the bladder. Many of these maneuvers create an inadvertent turn, accidental turn of the peritoneum, and with a consequence, pneumoperitoneum. But this is not important in the ETEP approach, as long as you have made a wide dissection of the space and no air escapes from the extraperitoneal space, which is usually through the ports. So you have to ensure that the ports are really tightened or airtight. Inadvertent perforation into the peritoneal cavity can be successfully addressed if this perforation occurs near the skin incision. You just have to expose that rent with the S retractor, grasp the inferior border, and slide the balloon over it to get the proper path. If the rent is far from the skin incision, you have to pull out and start again, more medial or more lateral to the initial path. In most cases, you will regain the extraperitoneal space. About the port placement, working ports are always placed under vision with the help of irrigation by a syringe and needle. For bilateral hernias in which a previous midline laparotomy creates de facto two distinct preperitoneal spaces, you can approach each one individually with a single incision in the epigastrium or with two incisions in each space. Consider always intraperitoneal laparoscopic evaluation, or what we have called a lap PIP, at the beginning of the procedure, just to confirm the presence of a hernia, or if it's bilateral, or to help in reducing an incarcerated hernia. And at the end of the procedure, wherever you think you have violated the peritoneum with your trocar introduction. And finally, pitfalls on the division of the arcuate line. When necessary, a small division of this line provides ample space. Watching scissors through the transparent posterior fascia extends on the or give you an advice or the stance of the division, and if you can see it through the transparent fascia, probably the peritoneum is not there, and you avoid really a pneumoperitoneum. As we have shown, placing a 5mm camera through one of the lowest trocars make this technique under vision, which is much easier to do. And as I said before, in case that a pneumoperitoneum ensues, and that is often with this technique, and especially with this maneuver, probably it doesn't interfere with the completion of the procedure as long as you have made a wide dissection and your trocar are airtight, because otherwise you will see an oscillating movement of the peritoneum, which happens when air escapes from the extraperitoneal space and is replaced by waves by the insufflator pump. So ensure that trocars are airtight, do a wide dissection, and pneumoperitoneum is not going to be a concern with this technique. What are the salient features of the ETEP technique? Well, we believe it's a fast and easy creation of the extraperitoneal space, the creation of a large surgical field, flexible port setup adaptable to many conditions and body habitus, tolerance to pneumoperitoneum, and better ergonomics. But if you ask me, I think the best advantage of the ETEP technique is that it facilitates the implementation of the critical view of the mouth-pectineal orifice. And you can do the ETEP technique for most of your inguinal hernias, as we do, but there are indications for which it is especially advantageous. Those are when you start experiencing the extraperitoneal approach. Most of our trainees has experience in the TAP approach, but little or no experience in the TEP technique, and they find easier to start their experience with this technique. When the distance between the umbilicus and the pubic tubercle is short, as happened in Latin America and India, when the patient has previous pelvic surgeries, in complex cases, for example, large inguinoscrotal, sliding, or incarcerated hernias, in the obese or post-bariatric patient in which you can avoid the panniculus. There is no other way to avoid the panniculus. If you do an open or a classic TEP or TAP, you're going to go through the panniculus. But if you do a subcostal incision in the ETEP technique, probably you are above it, facilitating the procedure. And also is the way to implement the robotic extraperitoneal approach for those who want to do that for inguinal hernia repair.
Placement. One of the main advantages of the ETEP approach is to facilitate the steps of the critical view of the mouth-patinal orifice. This is especially evident during performance of step 5. This is a large inguinoscrotal hernia. The sac is traction medially, while the elements of the core are dissected free laterally. This is a very deep inguinoscrotal sac. So we first divide the sac. And continue separation of the sac from the elements of the core, cephala. This is what is called parietalizations of the elements of the core. And sometimes, like in this case, should proceed even further cephala to avoid the elements of the core hanging in the middle of the space and placing a mesh tenting over them. Here we completed step 5. Another maneuver facilitated by the ETEP approach is the reduction of the distal sac to avoid or prevent seroma formation. We reduce the distal sac by traction the lateral aspect until the numus scrotum disappears, and then we fix it high and lateral into the posterior inguinal wall. We do it with the barbed sutures or sometimes tacks. This is step 8. Any mechanical fixation of mesh, or in this case, a distal sac, should be undertaken above an imaginary line between the anterior superior iliac spines. Please observe the distance between the aces and the point of fixation, well above any nerves. The large space provided by the ETEP approach allows placement of very large meshes like this 17 by 15 centimeter mesh. Step 7, one of the less understood steps of the critical view, is also made easy by the ETEP approach. After completing step 6, reduction of a lipoma of the canal, placing a grasper behind the fatty tissue, we place it under tension, and this facilitates division of this fatty tissue without touching the posterior wall, using very short spark of cautery with low voltage. Remember, nerves are against the wall. and not hang in the middle of the space of these fatty structures. We believe this step facilitates placement of the lateral inferior border of the mesh as a wedge deep into the space, preventing its displacement. It also facilitates mesh integration. This is the critical view of the malpectineal orifice as observed during the ETEP approach. This is a 55-year-old male patient with a 5-year history of falling from great heights. The patient underwent osteosynthesis placement. One of the main advantages placement. One of the main, to a male patient with a very.
Let me go one back because I want to show you this one. And you have to be very careful when you repair Spigelian hernias. They are not self-evident as they are in the TAP procedure. In the ETEP, you have to identify the arcuate line, to dissect the peritoneum from lateral to medial under it, in order to identify and repair an Spigelian hernia, and also to prepare the space for mesh placement in case you require. Here we are dividing the arcuate line and explained before. And this is the way to identify these Spigelian hernias. This small defect, but sometimes they are bigger and require well mesh coverage.
To a male patient with a very large inguinal hernia on the right, a small one on the left. After reducing the hernia content, let me accentuate on the proper setup for this ETEP approach. Initial incision is around 7 centimeters lateral and 3 to 4 centimeters above the umbilicus. Dissection proceeded, and we slid the balloon dissector over the posterior sheath as described before. But once we crossed the arcuate line, we turned the balloon toward the right inguinal area. We inflated the right side while keeping pressure on the left side to force inflation of the correct side. Through the inflated balloon, we can observe a large direct inguinal hernia. We then deflated the space and replaced the balloon dissector with a blunt tip trocar. As often happens, we try and fail to visualize the needle and irrigation through the umbilicus. We decided to place the left working port first, high in the left lower quadrant. And of course, under vision, we place this port first. Through this port, and with the help of scissors, we can prepare now the area for placement of the right working port. Now the needle and irrigation is visible, and we can place this port safely under vision. Reducing a large direct defect is comparatively easier than preventing seroma formation. And this case highlights precisely how to prevent seroma formation in these cases. We continue with the steps. Here is step 7. We advise adding a 5mm port on the opposite flank to expedite the repair of the contralateral hernia. After completing the steps on both sides, we obtain the critical view of the malpactineal orifice. To prevent seroma formation of this very large right direct hernia, we reduce the lax transversalis fascia and fix it high and lateral onto the posterior inguinal wall. Fixing this very large lax transversalis fascia to Cooper's ligament, in our view, precludes adequate integration of the mesh and predisposed to mesh eventration. We underwent this fixation using barred sutures, and we pull enough lax transversalis fascia until the pneumoscrotum disappears. That's our measure. We made sure we enforce step 8, and fixation takes place at least 2 centimeters above the interaces line. As in these large cases, we like to fix the mesh to the Cooper's ligament. A final view with both meshes in place.
There are common misconceptions about the ETEP approach that I would like to address today, especially for the repair of inguinal hernias. One of them is that it is indicated for the very specific hernias. No, we usually do for most hernias. It needs crossover? No, it doesn't. Most of the cases does not need crossover. Crossover is only reserved for those giant inguinoscrotal hernias with loss of domain, as Igor Belyatsky has shown. That the division of arcuate line is inherent to this technique? No, it is not. As you observed in the previous videos, if you go from opposite the hernia side, you don't need most of the time to divide the arcuate line. That only 2 port setups are possible, the one I just showed you? No, there are many other port setups. Probably you don't use them as often, but there are other ways to set the ports, and that's the beauty of the ETEP. And that it is for all inguinal hernias? No, it is not. Patients with reduced physiologic reserve probably are better suited for an open repair under local anesthesia. Previous meshes in the extraperitoneal space are not a good indication for this technique. You can address them by an open or probably a robotic tap procedure. That young females, for example, concerned with cosmesis, for us, are better suited for a TEP technique because it hides most of the incisions. As long as your current minimal invasive techniques allows you to establish the critical view of the malpactineal orifice and repair most of your inguinal cases, you don't need to change it. However, learning the ETEP access for inguinal hernia repair will open up for you a new world of surgical opportunities for the repair not only of inguinal, but incisional, ventral, and other extraperitoneal procedures. Let's go to the second part of this presentation, which is the ETEP repair for ventral and incisional hernias. Beyond the advantages we already discussed on working in an extraperitoneal space, the main advantage of the ETEP ventral hernia repair is that it can comply with the modern principles of abdominal wall reconstruction, which are a primary closure of fascial defects under physiologic tension, a wide prosthetic reinforcement of the visceral sac, limited fixation of prosthetic material, and a sublate placement of meshes, although alternative placement are acceptable. And those are minimal invasive and totally extraperitoneal. For those interested, there is an article that we co-author with Dana Tellem, the principal approach of ventral hernia repair, that is available to you if you want. What are the technical steps of the ETEP ventral hernia repair? First is marking of relevant anatomy. And let me emphasize here in the preoperative marking of the semilunar line under ultrasound guidance. This is a very important step, especially in the early learning curve, because the linea semilunaris is often more lateral than you would guess, especially with large defects. And this will give you a couple of needed centimeters to work in this space. So we always recommend it. The creation of the space is basically what we have described for the inguinal approach, but the pore setup varies according to the place of the hernia, the body habitus of the patient, the old scars and ostomies, and also the bone structures. The crossover is one of the most important steps described by Igor Belyansky. It allows you to go from one retrorectus space to another by dividing the medial aspect of the posterior sheath at least 1 centimeter below its junction with the anterior aponeurosis. Ribs, stoppa procedures or TAR procedure can be undertaken with this technique, or simply direct approach from outside the semilunar line. Posterior layer closure is very important. It prevents internal hernia, one of the typical problems or complication of this technique. It has to be done under physiologic tension with no undue tension, and it shouldn't involve the posterior sheath. It's not necessary, it's not a supportive layer. It's only a layer to separate the mesh from the intraperitoneal organs. The anterior fascial closure should be undertaken. It is much easier to do it robotically. For those who are studying this technique, there is no problem doing a hybrid approach and using the open small incision to help you do the closure easily and faster. The drain is optional. It should be placed if it's needed, and I mostly recommend it for those ETEP that extends lateral as a TAR. These are examples you have already seen many times. This is from Dr. Radu. This is the upper pore setup for inferior hernias, middle pore setup for middle hernias, and the inferior pore setup for upper. But let me tell you, we have been more and more performing this lateral approach, probably inherited from the robotic colleagues that have shown you that is shown us that is very flexible, even for hernias that are a little bit high or lower. And with only 3 ports, we can perform most of the midline or address more of the midline hernias. Here are some illustrations to show you the crossover, how a rib stoppa after crossover can be extended unilateral as a TAR procedure by dividing the posterior lamella of the internal oblique and the transverse muscle, or bilateral, as you can see here, obtaining a really wide space. And for lateral hernias, let me tell you, ETEP is one of the best indication for ETEP access for ventral hernia repair is the lateral hernias. We select those cases that are amenable for endoscopic approach. For those lateral hernias close to the semilunar line, L1, 2, and 3, we can perform a unilateral ribs, stoppa, and unilateral TAR without doing crossover. For those L1, 2, and 3 that impinge upon the semilunar line or are associated with other ventral defect, we perform a traditional ETEP rib stoppa crossover, and unilateral or bilateral TAR is needed. For lateral lumbar hernias, L4, we prefer a direct approach from lateral from the semilunar line. Let me show you some cases so you can understand. This is an L2 hernia, but it is separated from the semilunar line. Therefore, we can create this retromuscular space and then go laterally as a TAR, as shown here. This is the same defect. We do a unilateral ribs, unilateral TAR, and we have enough space to correct this hernia and to place an adequate size mesh. What about this one? This one already impinged over the semilunar line, so it is not easy to address this with a unilateral rib stoppa, especially if it's associated with an M defect. So in these cases, we prefer to do a traditional rib stoppa with crossover and probably a unilateral TAR, as shown here. Rib stoppa with crossover and unilateral TAR allow us to repair these two hernias. What about this L4 hernia? Well, you don't need to go medial to the semilunar line. You can go directly from outside the semilunar line with a balloon, with an OptiView, or better yet, if you're starting your practice with a Phillips approach, with a small 5mm port inside the abdominal cavity, directing your extraperitoneal dissection. As shown here, we go directly from outside the semilunar line. This is the same approach we do for triple neurectomy. Well, there are many combinations, as you can see, for the repair of ventral hernias, and discussing those in detail is beyond the scope of this presentation. What about the evidence and implementation of the ETEP for ventral hernia repair? Well, this was the first multi-center, multinational study on the ETEP led by Beliansky. We studied 79 patients, most of them obese. 34% of them had prior hernia repair, and not very small hernias. They have a mean defect area of 132 square centimeters with a mesh area size of 634 square centimeters. And this is remarkable, 52% of them require a TAR procedure. At that time, we started fixing most meshes with fibrin glue. We don't do it anymore. We don't use any fixation in most of the time. And as you can guess, the surgical time was too long. This has been reduced day by day, but at the beginning, it was really long. And as you can see here, the complications were negligible. The 30-day readmission was null, and the hernia recurrence was 0. Well, that has changed a lot, as you can imagine. As time runs now, we detect some inherent complication of this approach, and of course, recurrences have appeared. But it's really striking the improvement in the quality of lives of these patients especially concerning pain and limitation of movement. But it is reproducible. Let me tell you that I was awash to see that in a short span of time of only 2 years, there are more than 20 articles in the literature concerning the ETEP axis approach for the repair of ventral hernias, coming from the United States, Chile, Brazil, Colombia, Spain, Romania, Poland, Australia, and of course, India. Many authors from India has contributed with this. Igor and I were a little bit concerned of this widespread implementation of the technique because it's a very difficult procedure just to be so fastly accepted. So, but watching Konrad Walliser teaching his residents the ETEP approach for ventral hernias and seeing them perform this procedure has assuaged some of our feelings. What is the path to training for the ETEP ventral and incisional hernia repair? Well, we don't know for sure, but we recommend a profound knowledge of the anatomy of the extraperitoneal space, especially the natural boundaries and the neurovascular structures. It is a prerequisite for a safe performance of procedures in this space. Of course, revision of literature and videos, and hand-on courses that ideally should be in the cadaver model. The presence of mentor is really important, and I would say robotic training. This technique is facilitated for the best laparoscopic tower there is, that is the robot, especially for dissection into the space and for suturing. So if you have it available, it's worth it to do it robotically. There are intrinsic complications of this approach that you have to be aware of. The internal hernias from posterior fascia breakdown are not so frequent, but they appear and sometimes can be problematic because it can produce necrosis of the intestine. Hernias of the linea alba that also are technical problems that occur when the crossover is not done properly. And of course, large hematomas, because this is a large space that is easily filled with fluids like this one. There are unfinished tasks. Those are what is the proper training path for the ETEP access in these cases. We have to refine the indication. It is a 3 centimeter or less umbilical hernia indication without diastasis. We don't know, for some it is, but it has to be discussed. Probably is an overkill for those indications, is my belief. The reproducibility is also an unfinished task. We have to follow those studies long-term to see if it's really safe and effective. The discussion about TAR use and overuse, it hasn't ended. And also on the aesthetics consequences of the ETEP, probably is not the most aesthetic surgery, for example, for a large diastasis. And probably there are other options if you are looking at cosmetic result. I want to invite you, all of you, to join me in a voyage to the confines of the extraperitoneal space.
The port setup for the ETEP access approach is flexible. It depends on the type, size, and location of the hernia, scars from previous procedures, and the body habitus of the patient. One of the most frequent sites for the initial incision is in the upper left quadrant of the abdomen. Usually a 12mm incision is made and the anterior aponeurosis of the rectus muscle is exposed and incised. Long dissection is then carried downward using the index finger to pass through muscle and dissect the retrorectus space anterior to the posterior aponeurosis. A balloon dissector is introduced and directed caudally over the posterior aponeurosis. The balloon is extended to develop the space. Some prefer to use an OptiView and CO2 to develop the space without the use of balloon. At this point, you can see posterior fascia, the arcuate arch, and the left inguinal pre-peritoneal space. If needed, the surgical space can be enlarged by dividing the arcuate arch. For that purpose, a 5mm camera is introduced through the most distal trocar, and the peritoneum is dissected free from the posterior rectus sheath laterally. Then, the arcuate arch and the posterior fascia are divided cranially, medial to the semilunar line. It is very much the same maneuver as is performed from the bottom-up TAR procedure. The obtained view is an extended one on the left inguinal region. Both inguinal regions can now be dissected. The space that has been developed facilitates, for example, implementation of steps of the critical view of the malpectinal organs. We next pull back into the left retrorectus space to initiate the crossover described by Igor Beliansky by dividing the medial aspect of the left posterior sheath, crossing over the preperitoneal path, and then divided the medial aspect of the right posterior sheath and develop the right retrorectus space. With the camera now in the upper abdomen, we can see the surgical space for the rib stoppa technique. Observe the retrorectus spaces at each side and in the middle, the preperitoneal space. By turning the camera upwardly, we have a cephalad view of the same space. We continue our dissection in the preperitoneal space under the xiphoid process. As we proceed laterally, the diaphragm becomes evident. In these images, courtesy of Dr. Lu, in a very large subxiphoid hernia, he's extended his dissection further cephalad. Here's the area where the fibers of the transversus abdominis muscle gives way to the diaphragmatic fibers. Dissection should proceed under the diaphragm. On the right side, we observe the same area where the transversus abdominis intermingle with the diaphragmatic fibers. Dissection continues further cephalad under the xiphoid in a very delicate area to expose the central tendon of the diaphragm. And through this, you can observe the pericardium. The extraperitoneal space has been dissected all the way from the pubic tubercle to the central tendon of the diaphragm at midline. Now we're going to expand the extraperitoneal space laterally as a posterior component separation TAR procedure by dividing the posterior lamella of the internal oblique aponeurosis and the transversus abdominis muscle medial to both the neurovascular bundle and the semilunar line. Dissection proceeds even more laterally, with the patient progressively rotated into a lateral decubitus position. The extraperitoneal dissection has proceeded so lateral to reach the psoas, the quadratus, and the iliacus muscles. This illustration shows how both inguinal regions has been dissected and further extended on one side. The returictus space has been turned into one space by the crossover, and the extraperitoneal space has been extended laterally by a TAR procedure. ETEP access for these maneuvers has taken place medial to the semilunar lines. ETEP access to the extraperitoneal space can be performed directly from laterally to the semilunar line with the patient in a lateral decubitus position. This access can be performed with an OptiView trocar and CO2 dissection, or using a balloon dissector to identify and repair a lumbar hernia or perform a triple neurectomy.
Thank you very much.
Thank you, Professor. And
Lovely talk by Jorge Daes. Lot of people from different parts of the world has joined. Dr. Palanivelu is there, Dr. Senthilnathan is there, lot of stalwarts in the field is there. Before going to them, please, Dr. Jignesh, please.
yes, so Professor, wonderful talk. It has left all of us absolutely speechless. And it was almost like a full immersion course. You have taken a 360-degree in the entire extraperitoneal space today. And that was wonderful, absolutely wonderful. I take this honor to be moderating this session and be along with you on the same platform. There were a few questions which had come from the team. You have left us all speechless, but yet I would probably address some of them. What are, according to you, the contraindications for the ETEP approach? Do you see anything as a contraindication?
Yeah, the main contraindication of any method is lack of training. That should be the first contraindication. And
okay.
The rest of them depends if we are talking about inguinal or abdominal. In inguinal, there are many ways to do this. As I explained, if your method of repairing inguinal hernias is working, you don't need to change it, but this is an opportunity to expand your armamentarium for the repair of not only inguinal, but other hernias. On the ventral hernias, well, I would say that if the patient has active infection, many previous meshes and incisions, if you need to do a large paniculectomy, if you have an active fistula, probably the patient has a small physiologic reserve, you better choose another procedure because this is not properly to do it ETEP. Also, a small insignificant midline hernia, I don't think this is a proper technique to address with, because even though you can do the dissection limited, not to expand the whole extraperitoneal space, there are other procedures like an open or a tap procedure for an umbilical or a small epigastric hernia that can address the problem. But that's a tricky question because you want to start your experience also with the small one. So start your experience in the cadaver model, I would say, and then jump to the human in the indicated hernia.
I think you made a very valid point that lack of training is the first contraindication, and that was a very good message for all of us here. The second question which had come up was that how lateral does one dissect in the ETEP inguinal? Because sometimes you just keep going on, and then you feel you've dissected too much. So how do you define when do you stop laterally? Is it on the size of the hernia? How do you decide?
Yeah, but probably if you have a large inguinoscrotal or a sliding hernia, it makes sense. Even you can start from the lateral dissection before the medial. You don't have to follow
Okay.
the steps of the critical view in order. That's another misconception we can discuss with Dr. Lourier, a close friend and a master in hernia. In 15 days, we have a meeting on that.
Okay.
But
Okay.
what I say is that usually the dissection is not enough. From what I used to see, it has changed, but when we saw the old videos in the International Hernia Collaboration, the creation of the space was limited and they used to place small meshes. So I usually, even though you see a large dissection, is almost always accommodate a 17 by 12 centimeter mesh. And sometimes I have to dissect more to accommodate those. But it depends on the body habitus of the patient, if it's a lateral or medial hernia, and the size of the hernia.
Okay. Another point was, we could see that you are now educating to fix the distal part of the sac to the parietal wall. Does that in a bulky sac cause a problem with the superior overlap of the mesh? And do you think in future it's going to have a problem with the integration of the mesh? Because ultimately the distal sac always wants to retract back and there'll be a pull on the mesh all the time. So what are your views on that?
Well, that's a understandable concern. We have been doing this from 2006, and we published this technique in surgical endoscopy and have worked for us wonderfully. We usually saw big seromas. I know you say that you have to be conservative in the treatment of seroma, but some of them I have to operate and to treat them as a hydrocele and to remove through the scrotum dust capsule. So it is a problem if you operate in large hernias. And this technique has the advantage of reducing the working space. Now with the barbed suture is much easier. What you describe as the sac coming back to the testicle, to the scrotum, yes, that can happen, especially if you use tacks, because the pursuit of the tack through the mesh, it doesn't allow through the sac. It can go through the wall itself, but with the suture is very secure, and you advise the patient to wear a joy stick and not to pull the testicle that is going to be a little bit elevated. And in 1 month, you will notice that everything comes to normal because the sac atrophies. So I know there will be a part of the mesh that is in contact with the sac that is not going to be integrated, probably. But
yes,
you put such a large mesh in the space that probably doesn't make any difference, I would say.
Okay.
That's our explanation.
Okay. And we could see in one video you had used a lightweight mesh, a 3D lightweight mesh. So do you select in which cases would you put a lightweight versus a regular mesh, or because we are dissecting a large space, in a large space, lightweight macroporous would probably have a tendency to move around or shrink. So what are your opinions on that?
Yeah, I would say I reserve heavier meshes to largest defects. Probably direct defects more than 3 centimeters, it's worth it to use a heavier mesh. Sometimes I have to put 2 meshes because we don't have a heavy one. I have to put 2 light.
Okay.
But there are usually 35 grain per square meter, so it's not so light. It's enough. And when you go over the physical characteristics of the mesh, that's enough for most of the cases. So in summary, yes, I use very more heavier meshes in cases of large direct hernias or probably in recurrences. Otherwise, I use this one for almost all. This kind of mesh doesn't have good memory or undue memory.
Okay.
So they don't roll if you extend it properly. That's if you
Okay.
follow the steps of the critical view, that shouldn't be of an occurrence.
Okay. With the more and more understanding of the extraperitoneal space better, do you think in future the M2, M3 hernias, it would be better that we go bottoms up, because we are all familiar now with your ETEP space. So going bottoms up, and because the crossover will be very easy because we could see the right and the left side both at the same time. Do you think you would advocate that to shorten the learning curve of the surgeon?
I think it's more difficult to go from bottom up, definitely.
Okay.
It is more difficult to teach and to learn. I would say the
Okay.
lateral approach, the robotic people has shown us that the lateral approach is really, if you do it properly, is good for almost all midline hernias. You have to have a lot of tricks. I can share with you some of them. For example, you can initiate the incision above the costal margin. You can go 1.5 or 2 centimeters above the costal margin. You easily go into the rectus space, but you have more space there to address any hernia, as well as marking of the semilunar line, as I explained, that gives you more space, as well as instructing your anesthesiologist to give you a short period of really deep relaxation, muscle relaxation, that help you a lot. So with all those tricks, the lateral approach is really good for almost all hernias. You can approach them from bottom up, but it's not so easy to teach.
Okay. There was a question that you also mentioned about the lateral L2, L3 hernia, that you can go beyond the semilunararis, linear semilunararis. Would you advocate to use a balloon there, or you mentioned about the Philip technique? So can you just elaborate on that? How does one go beyond the linear semilunararis? Is it the finger dissection, the balloon?
Yeah, well, there are many ways to do it. If the patient has a previous operation in the area, you will find the transversalis fascia and peritoneum are thick. So it's so easy to do it with the balloon because you won't miss the proper path. In other patients, for example, for a triple neurectomy, that you don't have previous surgeries in the area, probably if you're starting your practice, it's better to do a Phillips approach. This Phillips maneuver is amazing. The other one is to do an OptiView, but you have to be prepared to penetrate into the cavity sometimes. So you can use one of the three. I would recommend start with the Phillips. When you have a patient with previous operation, try the balloon. And if you are an expert of using the OptiView for other procedures, well, that's another way to do it.
Okay. Any special clinical conditions where you would like to put in a drain in the ETEP space, or you don't drain them at all?
No, I put drains. First of all, if you observe oozing in the space, I would leave a drain even if I didn't do a TAR. But in most of the TAR cases, I prefer to put a small active drain there. One word about hematoma prevention. One of the most forgotten steps in the technique is to pull out most of the trocars under vision. That's usually the place of bleeding. If you pull out them blindly, you will lose an active bleeding into the space. So we, as a discipline, we do it every time. We see every trocar being pulled under vision to ensure that it's not bleeding. Sometimes we have to observe active bleeding, and we address it with a transfascial suture or in any other way. Even the camera plays. You retract the trocar first and then retract the camera slowly, and you can observe if it's an active bleeding or not.
I think that's a very important point, because most of the time the cannula is holding back the bleeder, and the moment the cannula is out, you can have the trickling into that space and it can create a problem. Any specific pressures which you keep during the ETEP apart from the patient position? Do you keep the pressure setting at 12, 14? Because sometimes at a high pressure, we have seen that a small rent can immediately open up the peritoneal cavity. So any comments on that?
I usually use a 12 millimeter mercury pressure, CO2 pressure. But when I'm suturing, of course, I lower it as low as 5 or something to allow an anterior closure of the defect or midline easily. And again,
Okay.
you have those extraperitoneal surgeries require good relaxation. You have to partner your anesthesiologist in this endeavor.
Okay. Thank you very much. Dr. Baiju, would we have any questions from the experts? We can see Dr. Palanivelu here.
Yeah,
Palanivelu, sir, would you like to, good evening, sir. Would you like to make, have any questions for Professor Jorge? Dr. Palanivelu is one of the pioneer advanced laparoscopic surgeons of India and done the laparoscopic Whipples, and he has a very keen interest and a team approach.
Yeah,
Can we have him unmuted, Dr. Baiju?
yeah,
Yes,
done,
sir.
man. Yeah, Jignesh, very nice, and I think I appreciate your wonderful talk. Yes, covered, excellent, and I really everybody participant today. I really truly enjoyed for inguinal hernia very central the way he has shown, and invented he has done. But of course, in India we don't use. Some people use a still balloon. We use a telescopic technique, same ETEP approach. Expanded, we can do that to reduce the cost wise, and technically we found easy also. But today he brought a point that lateral approach is the midline hernias can be dealt with the ETEP, ITAR and everything. And people bottom up, I used to see people struggling it. And whether robotic laparoscopy found lateral port is the best way to do midline or lateral hernias, including lumbar. That makes a difference approach. I think he brought out an overall view. Within the short time, he could give a brief evaluation from the beginning up. I think you brought all the questions and the people asked. I think nothing to say except appreciate him, and very nice.
Dr. Pala,
Really
thank you
wonderful.
for your
Enjoy
kind
your
words.
talk. Very nice talk.
Thank you, Dr.
And,
Palanivelu. Thank you very much. You are very kind, my friend. Thank you.
No, truly,
Yes, thank you for your
today
compliment.
I looked at your talk, wanted to pray and see that. I enjoyed it. On behalf of Indian surgeons and a lot of international participants were there today because your talk, you're something we enjoyed.
Thank you.
Wonderful.
Well, and you don't have anything else useful to do on a Sunday, I guess.
in fact, it was Dr. Palanivelu who released the logo for this foundation, Senadhipan Education Foundation. We are glad that you are here, sir.
Baiju, you brought
you.
a great person today and made it a common subject. Very nice. This is a future surgery, and everybody is learned it. Very nice.
Thank you, sir. And a lot of other stalwarts like Yuri Nosky, Victor Vadu, Javier Lopez. Lot of people are there. Dr. Javier Lopez, if he is online, please open your video. And David Lowry also is there. Dr. David Lowry, open our video.
Mr. David, would you like to offer your special comments? Because you've been a very strong pal with Jorge.
I have no questions for Jorge. Jorge, you covered this so nicely. I only comment that the world is indebted to you, not only for developing this access that applies to so many different hernia scenarios, but perhaps more importantly for disseminating and teaching this in such a clear way. So thank you, my friend. Really, we are indebted.
Thank you so much, David.
Have you here.
Thank you so much.
Dr. Ashwin Masurkar. Ashwin.
Do we have any more questions from you? Yes, Ashwin, do you have any question for Professor Jorge?
It was just a wonderful presentation, and probably Professor Jorge is probably familiar. Being done earlier, I used the transabdominal approach for ventral hernia, I call it the TARM approach, and it's now published in the World Journal of Surgery. Been doing it for many years. Kept trying to perfect it, and now came across. So the thing that I found is we add a transverse incision, and we see a cross-sectional view of the linea alba as compared to the ETEP where you have a crossover. So just like TAPP is easy to understand the anatomy for a novice surgeon, I find probably the transabdominal retromuscular approach could also be an easier way to understand ventral hernia anatomy. Just a thought from my experience.
Thank you. Thank you.
Yeah.
Just check out if we have any more questions, because it has been a long session.
Javier Lopez has opened his video. So, some comments. We are actually happy that you are here. Comments from you.
Oh, thank you for the presentation, Jorge. Excelente, como siempre. I just pointed in the chat that I came from an open surgery school for doing ventral hernias. And when I watched your videos at the beginning of the description of the ETEP technique with Igor Beliansky and Victor Radu and Ramana, I just had the feeling that suddenly I saw the technique that was suitable for open surgeons, because it was exactly what we were doing in open surgery, just with a minimal invasive approach. And I say that it's a conversion point between the IPON surgeons also, because during the past years, I argue a lot with Salva Morales and many lab surgeons talking about the restoration of the anatomy in the ventral hernia repair. And I had the feeling that what we were doing, the open surgeons, was better than the IPOM. And suddenly with this technique, all of we agree that it was the best thing to do. You joined the anatomical restoration of the anatomy of the patient with the minimally invasive procedure. So I think it has been the conversion point, the convergent point between both groups of surgeons. So nothing else to be said. Excellent presentation, and I think is the technique for the repairs of ventral hernias.
Gracias, Javier, por tan amables palabras. Lo agradezco en el alma. Muchas gracias.
Thank you.
I request Dr.
Thank you so much.
East is there from Czech Republic. Dr. Barbara East.
Barbara, would you like to say something? Barbara? Okay. So, Dr. Baiju, I think we have covered up most of the question answer sessions.
Danny Rosen.
Okay.
Just ask him to unmute.
Yeah.
Hi, everybody.
Yes, Danny. Good evening.
Hi, good evening. Very good talk. I really enjoy it. Every time I hear Professor Daes, it's like his way of explaining things, explaining the anatomy, like he's preparing the next generation. So I really like his talks, and it was excellent as always. Thank you very much.
Thank you, Danny.
Thank you, Dr. Danny.
Thank you. I appreciate it.
Okay. Dr. Rahul Mahadar is here. Rahul has also been a very keen supporter, and we've all met at IHC, Professor Jorge. So Rahul, would you like to say something? Because we have been pushing the baton and moving around across India, spreading the knowledge and training more and more people. Rahul, would you like to say something?
Yeah, it was a excellent presentation by Professor, none other than the pioneer of ETEP procedure. And I'm a great admirer of this particular procedure. I have learned from him when he was visited India in 2018, Delhi meet, IHC 2018. And it was very wonderful talk, explaining all aspects of ETEP. And he is always very illustrative, and the critical view of myoperitoneal orifice that he has described along with Ediphelix is a wonderful thing. for any novice surgeon to know and to do the proper steps for the inguinal hernia repair by ETEP technique. And I really appreciate Dr. Jorge Daes, Professor Jorge Daes, for giving this wonderful talk. Thank you, Professor.
Thank you, Raul. I
Thank
enjoy
you.
your
Thank you, Raul.
ETEP repairs.
Yeah, thank you.
Thank you. Thank you so much. We have Professor Abhay Dalvi from KM Hospital, where I work with him. And Professor Dalvi has been a very strong supporter for educating and taking the learning of the students further. Dr. Dalvi, would you like to say something? He is the coming president next year for the Indian Association of Surgeons. Dr. Dalvi.
Dr. Daes.
George, I actually graduated in the open era, then formed the department of minimal access surgery at one of the premier institutes out here. Jignesh is one of my colleagues now, and I feel so proud that these people are really propagating knowledge about hernia. And my hats off to you. I have to confess, for the first time, I have really understood the concept of how to go about doing a laparoscopic repair of hernia properly. The E-axis, I think, is one of the best ones to tackle inguinal hernias. I will have to listen to you again as far as the ventral and lumbar hernias again, whenever I get opportunity. Thank you so much for coming and delivering this lecture.
Thank you for your kind words. Thank you.
Thank you. Dr. Pavanendra Lal is there. Can you please unmute your audio, sir?
Yeah, thank you, Professor Jorge Daes. It was absolutely amazing to listen to you. I've been doing TEP for the past 21 years, but I took to TEP ETEP view from your paper, from your pioneer presentation, and started the project on studying it for inguinal hernia and for extending it for ventral hernias in ETEP RS. And you made so many points so clear today for all the viewers, and most importantly, stressed about the do's and don'ts about the procedure. Thank you very much for this very excellent presentation. Top class indeed. Thank you very much.
Thank you, sir. Thank you.
Thank you. Dr. Parveen Bhatia.
Yeah. Good evening, Dr. Jorge Daes. An excellent presentation. I have always been impressed with your critical view of myopectineal orifice, and then going on for ETEP for inguinal hernias and then for ventral hernias. You have beautifully demonstrated the fixing of the direct defect to the Cooper's ligament. Do you fix the indirect lower lip sac also to the posterior wall or not?
No, it's just the lateral border of the sac, of the divided distal sac. The lateral border, we pull it. And you know what is your measure? You observe the pneumoscrotum. The pneumoscrotum, as you are pulling, is going to disappear. In the point it disappears, that's the point you will close it. You don't use the other border because you can create a hydrocele by closing the distal sac. That's why we pull just one side. A space that is round is going to be converted into a flat structure by pulling just the lateral border. That's the reason why.
Sure. And frankly speaking, we have been doing ETEP with the optical port entry, and we thoroughly enjoy that. We always remember your space, and we thoroughly enjoy in each and every case.
Oh, thank you, Fabian.
Thank you. God bless you.
God bless you. Thank you.
Jignesh?
Yes. So I think we have overall had a wonderful session, Professor. We thank you once again for your absolutely speechless performance and a great talk. It was almost like a full immersion in the course of ETEP, and you have taken us 360-degree around. And I'm very happy that I have my senior faculty members and teachers here along with me, and we've all shared this wonderful experience. So any last take-home messages from your side, Professor Jorge? Any take-home messages you would like to give?
Well, the message, I'm overwhelmed for your comments. I thank you very much, Jignesh, for inviting me to this presentation, to the Senadhipan Foundation for supporting this event, and also to Ramada Balasubramanian and other Indian surgeons who have instilled in me the love and respect for the Indian surgeons. Thank you very much. Thank you for the opportunity.
Thank you,
Thank you very much
for the wonderful lecture and beautiful videos. Actually, we had 340 people who were logged in. And actually, we are expecting almost 3 times because we are streaming this one in Facebook and YouTube. Almost 900 people watched live online. Thank you so much for the wonderful presentation, and we wish you a presentation in the future also. Over to Jignesh.
Thank you very much.
Yeah.
Thank you.
Thank you very much, all of you. Good night.
Bye-bye.
Safe
Good
and
night.
take care. And you have a wonderful day at Bogota. I'm sure it's going to be a nice sunny day for you, and you enjoy yourself. Thank you so much.
Thank you
Thank
all.
you, my friend. Bye-bye. Bye-bye.
Bye-bye. Bye-bye to everyone. Thank you.
Thank you.